workshop in the clinics with Dr. Patrick and Dr. Paul. Dr. Patrick and Dr. Paul come from the US, they are physicians there, and they have come here to take this workshop with us. So it's our pleasure to have them here. I hope you will all enjoy it and learn from the lecture from the professors. This workshop has come as a collaboration with Dr. Tim and Dr. Marie, who also come from the US, but are now working in Stool. More about their work, I'll let Dr. Tim talk, and then we'll begin with the lecturers. Thank you.
Thank you, Nëntor. Thank you, everybody, for your patience. We really appreciate it as we fought our way through the circles and traffic of Pristina. It's nice to be here. We had a wonderful coffee and lunch, and we have full stomachs, and we've got lots of energy. So we're looking forward to speaking with you. Just a brief word about who we are. We come from the US in an organization called Medical Education International, which is a group underneath the banner of Christian Medical and Dental Association. Our doctors are all in subspecialty fields, and they're volunteers. They come here to teach what they know in medicine with our colleagues in all of the Balkans. But this is their first time to speak in Pristina, so we're very, very excited that you would invite us, that you would spend some time with us when you have lots of other things you could be doing, like probably studying. So thank you for your time. First, I'll introduce Dr. Patrick Young. Patrick's been in the Balkans now 4 times, down to Macedonia and Skopje, and he brings with him a very strong CV. Just suffice it to know that he's an expert in the field of gastroenterology, particularly the use of ERCP and other modalities. He's going to talk to you today, as you can see, about common issues in gastroenterology. So without any further ado, Dr. Young, the table is yours.
Thank you very much. So here, is it common that I would take my mask off if I'm speaking? Or leave it? Okay, I will do that then. So yeah, thank you very much for having us out. I'm going to aim this mic. Can everybody hear me okay? Out there? Perfect. Yeah, and so as Dr. Tim was saying, I'm a gastroenterologist, and what I do, some of it is very specialized procedurally. What I'm going to talk about today are not those things, because most of you are not going to be procedural gastroenterologists, and so I want to talk about some things that if you're an internal medicine physician, a family practice physician, if you're a gynecologist like my wife is, these are things that you're potentially going to see. Some of these are hopefully worldwide things and not just things that I see in my kind of unique practice outside of Washington, D.C. So we have disclosures everywhere we go. So nobody paid me to say these things. I do work for the U.S. government, and so I'm supposed to tell you that just because I think it doesn't mean they think it, although by the end of this talk, if they were here, they would. So one of the things, I understand you're all medical students, is that correct? So me too. So even though I have a professor title, I'm always learning, right? All the time. It's a lifelong thing. And so one of the differences, though, when you're starting, you're learning from the internet, you're learning from books, you're learning from each other. As you go on, almost all your learning is going to be linked with some patient scenario, somebody who's sitting across from you in the office who you need to try and help. And so because that's how you're going to learn for the rest of your life, that's how we're going to learn today. This is all case-based stuff. So I'm going to present clinical scenarios. You're going to get to think about what you think the next step or the right answer is. I'm not going to tell you immediately. We're going to kind of walk through the cases, and then by the end, it will be sort of obvious, hopefully, what the answer is, but I will tell you the answer. I'm not going to leave you hanging at the end. So, and these are, again, common things. We're going to talk about constipation, and then the second thing is what's called gluten sensitivity. Is that a real thing? Is it not? How important is it? So case number 1, this is a 43-year-old woman who comes in and she tells me, Doc, I have constipation. What does she mean by that? Well, she has a bowel movement every other day. She strains sometimes when she has these things, and she describes them like rabbit pellets. I don't know if people here describe stool in the same way, but she has kind of these small, pebbly stool as opposed to having like a sausage-like stool, which is what Dr. Oz told her she should have on the Oprah show. So she also doesn't always feel like everything comes out. Right? So hopefully you're comfortable talking about poo because I'm a gastroenterologist and we're going to have a lot of that language here today. So she just feels like, when I go, I still have to go even though I feel like I'm done going, if that makes sense. She does not have any alarm symptoms, and what do I mean by that? Well, she's not bleeding, she's not losing weight, she's not having nausea and vomiting like she has a bowel obstruction or something. She just has this constipation. And nobody in her family has ever had cancer of any type, much less cancer of the colon. So you feel a little bit better about that. So that's number 1. She's tried over-the-counter laxatives. So I'm sure here, like where I live, there's a lot of stuff that you can get over the counter to try and help yourself, and most people have done that before they come to us. These include senna derivatives, so those are stimulant laxatives that you can get in teas or pills, polyethylene glycol, which is a non-absorbed osmotic agent that just draws water into the colon. And then she's tried fiber, both supplementing it, like a can that you get and you put it into the water to make a slurry, or dietary. She's tried all that stuff, and none of that has made her better. And so that's why she's with me today. And so who's familiar with the Bristol stool scale? Have you guys seen this before? Raise your hands. Anybody? This is the audience response system here. So a few of you have. So this is super helpful, right? Because when you ask somebody to describe what their stool is like, most people lack a language to tell you, or what they tell you doesn't fit into your category, right? So this is sort of useful. On the left, if you go into one of our offices, this is actually on posters, so people just kind of point at what they want. There's these Brits, who also made the Bristol stool scale, put together this other thing that is more based on what people might be familiar with. So I don't know if you have Maltesers here, but if you have Raisinets, if you have Goobers, if you have some kind of little chocolatey candy, that's kind of what a Bristol 1 stool is like. So that's what this woman has. And then you can kind of see down to the end where it's watery and has. So this is useful to have in your vocabulary as you're learning how to talk to people about this. So the question is, somebody comes in with these complaints, what do you do next? And I'm going to give you some choices. One, you start lubiprostone. Raise your hand if you know what lubiprostone is. So yeah, so it's a chloride channel activator. So it's an anti-constipation medicine. You may remember that's how cholera works too, right? It opens up chloride channel and you just start secreting lots and lots of water. So this medication is kind of like controlled cholera. I don't describe it to patients like that because nobody would take it. But that's basically what it does. And it is helpful for constipation. 2, do you perform a rectal examination? 3, tell her to drink 8-ounce glasses of water, right? That's what my grandma would tell me to do if she were still here. And so, that seems like okay advice. Or D, refer her to a gastroenterologist because you just don't have time for this today, okay? And I can tell you D is never wrong. That's what I tell my audiences. You can always refer them to me, but most of these things you can probably handle without me. Okay, so the first thing that I want to leave you with is constipation is complicated. I think it's one of those things, like you may remember in anatomy, like I remember my first day of anatomy, we're talking about the bicep and the tricep, and I thought, this is easy, I already know all these muscles, right? I feel like we start constipation, we feel like, I know what constipation is, right? I could describe constipation. Well, it turns out, I think we underestimate constipation and how many forms that it can take. So history, and this is a good general rule, relieves mystery. So, it means a lot of things to a lot of different people. And if I'm going to have somebody here, if you had to define constipation for me, how would you define it? So you made the mistake of looking right at me when I asked the question. So how would you said, no, you don't know. Does anybody feel like they have an idea for how they would define constipation? Or give me a definition for constipation. Not have to be all of the definition. Yes, ma'am.
Someone wants to do, they cannot do that for a period of time.
Okay, so somebody who wants to be able to go to the bathroom but cannot do that. I think that's certainly a definition of constipation.
They cannot do that. Also, if they're trying, some of the time they can come out with blood if they're trying really hard.
Right, with the straining, for sure. Yep, that's absolutely correct. Anybody else have thoughts? Yes, ma'am.
The feeling that you want to go, but you cannot, the feeling that you still need to poop, but you cannot go anymore.
Right, yeah, exactly. Yes, I would call that
the feeling that that you haven't done that completely. Like I read that this is the accepted definition or for constipation.
Yeah, that is one of the forms that constipation can take. Yeah, and so I agree with that. Anybody else have other things they would add to those definitions? Those are both great. No? Okay, perfect. So one of the things that I often get from audiences is a number. They say, well, if you have fewer than 3 bowel movements a week, that's constipation. And that's correct. It isn't how most patients who are coming in complaining aren't usually complaining only because the number is off, right? It's something that they feel as well. Some people talk about the quality, like is it easy to pass a bowel movement, or do I have to strain or work hard to have it, which is what you're describing. Some people talk about completeness, which is what you were saying, like I feel like I can go, maybe even go every day, but I don't feel like I empty every day. And that can be uncomfortable, right? You need to know how long it's been going on for. Is this something like when you were a child, your mom had to give you medication for constipation, when you can start to think about things like incomplete Hirschsprung's disease, maybe the nerves down there don't work quite right. Like if they have the full version, you're going to know that when they're an infant, but there are incomplete versions you may not know. Or is this something that started in the last year or two? Those are very different in how I think about them. Are there other things that come along with the constipation? And then your medications is one of the first things I tell people to think about. Because if you look at the list of potential side effects, every medication causes either diarrhea or constipation, and some of them cause both, right, if you look in different people. And so it's always important to look at the timing. Are there new medications that may be contributing to this, particularly calcium channel blockers, beta blockers, medicines with anticholinergic side effects like tricyclic antidepressants, those kind of things. So there are really three ways to categorize constipation. The first is slow transit, and in my simple way of thinking, before I was in medicine, I thought all constipation was slow transit, right? Isn't that how it works? Your bowels move slowly, and so you don't poop enough. It turns out that's the least common type, and we'll talk about that. It means you have infrequent bowel movements, and usually these are people who tell you they go once a week, once every other week, and they really don't feel the urge to go in between. They might sit down because they feel like I should, like it's been a while, it's time, I should sit down and try to have a bowel movement. But they don't feel that urge to stool like most of us probably feel. Normal transit actually represents about 50% of all of this, and this includes things like irritable bowel syndrome with constipation that would fall in this category. They often go a normal number of times, but something else is off. And then there's pelvic floor dysfunction. And so those folks are generally your strainers, people who feel like they don't empty all the way, and then people who have this, what we call skibbolus or type 1 stool, those little pellets or Maltesers kind of stools that come out. And then the other thing is they'll often do stuff to help them have a bowel movement. So anybody who comes in with constipation, I ask them, is there anything you have to do to allow yourself to have a bowel movement? And I leave it open like that. One, because it's super entertaining to hear the answers that I get. It is amazing what people will think of. But a lot of times they might say, well, I push up in that area, what we know as the perineum, right? They say the area between my vagina and my anus, or sometimes women will actually push into their vagina because they feel something bulging. They'll push back on that, or they'll elevate their feet up, and that will help them. They'll kind of physically push on their abdomen. Those are all signs that there may be a mechanical problem like pelvic floor dysfunction going on. And if you let pelvic floor dysfunction go untreated, it can actually slow down the rest of your bowel. The way I think about it is, if you had an assembly line and you were responsible for pulling stuff off, and you notice that the person who's doing that isn't pulling stuff off the assembly line, you're going to slow it down, or else things are going to get backed up. And so your body senses that the train's still got passengers on it, so to speak. We're not going to send another train down. So, and here's just sort of the breakdown of the different types of constipation. And so this is what we think this person has, right? So they've got straining, they've got incomplete evacuation, they've got this Bristol 1 stool set. And so what do you do next? Well, you perform a rectal exam, right? Because that's how you're going to diagnose this, but not just a regular rectal exam. And I'm going to give you a superpower when you leave here. You're going to learn how to do a gastroenterologist level rectal exam. So, if you were looking for a skill to take home, now you're going to have a skill to take home. To understand how to do the exam, though, we have to kind of go back. For me, it's back. For you guys, it may not be that far back, to anatomy, right? And so you remember, if you look on the left, top left here, that is what your rectum looks like now, when you're just hanging out. And you'll notice there's actually a couple of turns in there, right? It's not a straight tube that leads right down to your anus, because if it was, every time you coughed, laughed, jumped up and down, whatever, you would probably leak yourself, because the external sphincter, turns out, is not that strong a muscle, right? We leave that to things like the masseter. So what happens at rest is that puborectalis muscle, part of the pelvic sling, is actually pulling your rectum. Like continually, that muscle is continuously engaging to hold that anorectal angle, so that things have to make a bend, and that bend takes more force. When it's time to defecate, you look at the next one over to your right, then that angle straightens out because the puborectalis relaxes and it makes that line straighter, right? So your rectum senses that there's a certain volume of stool. It sends that signal, relaxes, and then you push both with your abdomen, you relax your external anal sphincter, your internal anal sphincter reflexively relaxes, and then you can defecate. And for dysenergic defecation, that relaxation either doesn't occur, or you have paradoxical squeezing. So rather than loosening, it squeezes up. And so, because of that, let's cycle through there, you're going to do a special kind of a rectal exam that allows you to feel that. And you may think, well, I don't know if I'm qualified to do that. You know, the mechanism sounds fairly complicated. But when it's been studied, actually, a rectal exam that shows you have this condition is 87% specific for pelvic floor dysfunction. And so what makes a good rectal exam? Well, first you're just going to look, right? That's sort of obvious. You know, you see big hemorrhoids, you see fissures, you see things like that. You do a sensory exam, and by that I mean you're going to take like a little piece of cotton or something and see if they can feel that. You take like the little end you break the cotton tip applicator and you kind of poke them, and does this feel sharp in these different places? You do that next. Then you're going to put your finger in, and you're actually just going to feel around, make sure you don't feel lumps and bumps and things inside. But then you're going to do the dynamic part, and that's where you're going to make the diagnosis. So first you have them squeeze, and I tell them, you know, pretend like you're trying not to pass gas in a public situation, right? So that's the easiest way to do it, right? So, or maybe some of you don't have to pretend, I don't know. But, and then I tell them to pretend like my finger is a piece of stool, and you're going to push it out. And when you're doing this, you should have one finger in the rectum and the other hand's actually on the abdomen, because their abdomen should squeeze when that happens. And then the pelvic floor should sink about 1 centimeter down, and the squeeze on your finger should relax. So if any of those things fail to happen, that's pelvic floor dysfunction. Okay? And that sounds like a lot. It takes a quarter of the time to do the exam as it does to explain the exam. So it actually goes fairly quick. Okay, so you diagnose pelvic floor dysfunction. Now what? Right? So there's a few treatments, and some of these, you know, maybe not as available depending. The number one thing is pelvic floor physical therapy. So what they do is you actually go in and they take electrodes that are like EKG electrodes, and they put them down, kind of down by your bottom, and then they have you do all the things I just described, and then there's a tracing that comes up, and that tracing generally doesn't match what ideal is, so they show them what it's supposed to look like, and then they work with them to train them until those curves overlap. It takes a couple of visits, and then everything else the patient can do on their own. 85% effective for relieving this kind of constipation. Fiber is important, so she's tried fiber, but she needs to keep doing it. And then the other thing is good toileting habits. And so when I say that, does anybody have an idea for if I'm trying to teach an adult what the right thing to do is when they go to have a bowel movement? What would I tell them? Does anybody have any clues? I'm sorry, go ahead.
Making a specific time to go every day.
Yeah, perfect. Exactly. Yeah, we call that timed voiding, right? So you have a certain time, you're like, okay, after breakfast, I'm going to go and have a bowel movement every day. Yep, that's definitely one thing. The same thing. Okay.
Or after eating something. For example, after drinking coffee.
Yeah.
After drinking coffee,
Right.
making it regular to go in the bathroom, even if you don't have to go. Maybe making a regular
Yeah, I mean,
thing.
coffee is a stimulant. Yeah,
Yeah.
and so are meals, right?
Yeah,
So we have
yes.
what's called a gastrocolic reflex. So we eat, and then our colon wants to empty because it knows that the stomach is
Exactly.
full. Eventually, that's going to make it down south, right?
Yeah, exactly.
So exactly.
Yeah.
Yeah. Anybody else? All right. So those are all good, and those are on this list. So the other thing is, I would say, limit the amount of time you sit. So some people will feel like, you know, I should have a bowel movement, so I just had a cup of coffee, I'm going to go sit, but they'll sit for half an hour, they'll sit for 45 minutes. That's terrible. And it's terrible for a couple of reasons. One, you don't want your pelvic muscles unsupported, hanging out in space that long. It creates hemorrhoids, you can get anal fissures, things like that. You can sort of get into the psychology of failure, too, by being there too long. So I tell people no more than 10 or 15 minutes, and then if you haven't gone, great, you get up, and you to wait till your next time or until you'll feel the urge to go. And that's important. Now, there are some people, and I don't know if anybody knows someone like this, where that's kind of their escape. So they'll go to the bathroom and like, nobody bugs me in the bathroom, my kids don't go in there, my spouse doesn't go in there. So if that's true, that's great. Close the lid, sit on there, read a book. That's all great. Just don't have your bottom hanging out in space, right? That's the thing. So if that can be our little secret if you need to be in there. That's okay. And then the other thing is, if you have to go, right? So a lot of people, depending on their job or things like that, they feel like, well, I can't just get up and go to the bathroom. And so they'll feel the urge to go, but they have to suppress it, or they choose to suppress it. Like one of my kids, I won't tell you which, I won't dime them out, but they would call themselves a home bowler. It's like I'm only going to the bathroom in my house. I'm not going to the bathroom somewhere else, you know? And so you can learn not to go when you feel that urge, and that can actually create constipation, right? In the same way that pelvic floor dysfunction can. That's particularly true in children, but it also can happen in adults. Timed voiding, which is what you were describing. And then adjuncts. So I was talking about some people have learned that if you put your feet up, that helps you have a good angle to go to the bathroom. So they make products like this, and I don't work for these people, but this is the Squatty Potty. Have you guys heard of the Squatty Potty? If you haven't, go to YouTube. There's great like rainbow unicorns pooping ice cream. It's a great thing. But this does help, right? I mean, you could use books or blocks, or you don't have to use something like this. But raising your feet up definitely helps. Okay, so those are the things that you could do. Any questions about that, or would you like me to hold questions to the end? I can do either one. Okay. So case number 2 is a 32-year-old woman, and I feel like I've seen this woman many, many times. She has 3 to 4 oatmeal-like stools every day for years, for as long as she can remember. They're mostly in the morning after breakfast, so they're not evenly spread out. She'll get up, she'll have a bowel movement after she eats, and then she'll come back like 3 or 4 times, and then she's done for the day. So all before noon, she's had 3 or 4 bowel movements. Doesn't wake her up at night, none of that kind of stuff. She does feel bloated, and sometimes that bloating is relieved when she has a bowel movement. She has urgency, so when she got to go. But she has never lost her stool. And again, she's not waking up at night, which would be an alarm symptom and make me worry about something else. But she does feel tired a lot. That's her one. When you ask her sort of a generalized review of symptoms, she's not having bleeding, she's not losing weight, but she just has this fatigue that she really can't explain otherwise. And she got on the internet, and the internet says gluten is bad. So I don't know if your internet says that, but my internet says that. And so she decided she's going to stop gluten, and she came to me, and she goes, "You know what, doc? I stopped gluten, and I actually feel better." And so we have a discussion about that. And she says, "Well, can I just stay off gluten forever? Do you think I have celiac, and can I stay off gluten?" So, all right, so what do you tell her? So here's the audience participation part. You definitely have celiac disease, and you should totally remain off gluten forever. Okay, that's 1. 2, you may have celiac disease, but you'll need to be on gluten, eating gluten-containing foods for me to test you. C, you may have celiac disease or another food sensitivity or IBS, or stay off the internet. D is definitely what I want to say, but that's not going to work. So it's one or the other. So you got 3 choices instead of 4. So, this is actually a t-shirt that I found on the internet. The question mark is mine, but the other is not. So somehow we've gotten this perception. We love to select food groups that are bad. So sugar was bad, and then fat was bad, and then carbs in general was bad, and gluten specifically was bad, right? All that stuff is false-ish, right? I mean, it's a balance of things. But this is something that really has taken off, and the concept of gluten sensitivity, independent of celiac disease, is also something that we're going to talk about. So you can test for celiac in people who are not taking gluten. And often if you feel better off gluten, it is really hard to convince people to start eating something that makes them feel bad, right? I mean, I wouldn't do that really, And so I think it's good that we have this. So what you can do is what's called a haplotype. So everybody who has celiac disease is positive for either HLA-DQ2 or DQ8. And so if you don't have one of these, you don't have celiac disease, right? That's 99.9% true and not 100. So if you become a gastroenterologist, call me, and I'll tell you about the 0.1%. But this is a good general rule to remember. So it has a great negative predictive value. So if you see me and I test you for this and you don't have it, you don't have celiac, that's all I have to do. And we can be done with that. Now, if you are positive for this, it doesn't help, right? Because 30% of normals or non-celiacs have one of these 2 haplotypes. So all this really does is give you permission to have celiac disease, right? It's necessary but not sufficient to give you celiac disease. And so it's independent of gluten exposure. So you can eat all the gluten or none of the gluten, and this is going to be the same, right? It's genetically determined. And if it's positive, I need to do something else. And then we'll talk about what that something else is. If it's positive, then I have to give you gluten, but I don't have to give you a lot, like 1 piece of bread per day, a muffin per day, for a little while, for 2 weeks, right? So they kind of write out some of the symptomatology. And then the test to get is a tissue transglutaminase, IgA, and then a total IgA. And the reason for that is IgA deficiency is the #1 selective immunodeficiency. That's all the immunology I'm going to say in front of a rheumatologist before I misspeak. You can also get a deaminated gliadin antibody if they're IgA deficient. That works. You can get an anti-endomysial antibody. I could tell you these, at least where I practice, are more expensive and they're difficult to run. And so in centers that are great at it, you get good results. In centers that are not great at it, you get very spotty results. You need monkey esophagus to run this, believe it or not. So that's your trivia point for the day. And so I don't really ever order these tests. And so she doesn't have celiac. So that's fantastic. So we're done, right? I wish. So, I tell her this is probably IBS. And it's important to know that IBS is not a diagnosis of exclusion. Has anybody ever heard that? Like that IBS is a diagnosis of exclusion? Tim has. Yeah, not for me, brother. I'll tell you. Because there's lots of stuff which can cause diarrhea and abdominal pain. And it was ludicrous to think that I'm going to rule everything out, right? It'd be, it would bankrupt the system, number one, cause a lot of anxiety for the patient, and it's just not necessary. So if you generally understand the diagnosis, and I'm going to sort of talk you through that here in a second, then it turns out that you're 95% specific. Just taking a history, not doing your exam, not getting any labs, that if you talk to the patient and you get the story, 95% of the time, you are going to be correct. And so what is NICE, that's the National Institute for Health and Care Excellence, a British organization. And here's the chart for what this means. So it's important to know that it has to hurt. So if you don't have pain or discomfort as part of this, if you just have diarrhea, that's not IBS. You have to hurt to have IBS. And you have to hurt for a while and have the symptoms for a while, meaning greater than 6 months. There's a ton of stuff, as you probably know, that causes transient diarrhea and abdominal pain. You eat the wrong thing, you get a little virus, you travel and your microbiome changes. There's tons of stuff, right? But if it's persistent, then that may be IBS. Your stool passage changes, bloating is common, not necessary, usually made worse by eating, right? GI diseases usually are impacted by GI function. And then it's also important to recognize that things you wouldn't necessarily think of as being irritable bowel syndrome are highly correlated, right? So a little bit of nausea, some backache, just feeling tired and lethargic all the time, super common and should not dissuade you from thinking that the person has IBS. And then there's a few lab tests you can get. One of them is celiac. So celiac is about 1% worldwide prevalence. So it's common enough that you should check for it when somebody comes in, as well as a few basic things, blood count, sedimentation rate, CRP. Okay. Is there a way? I think he's working on it now. Yeah, so this is her case. So it kind of sounds like that, right? She's having these loose stools, bloating, relieved with defecation, feels tired. What you don't need to do in IBS is these things. So I get a lot of referrals to do colonoscopy in IBS. If that's all you have, that is totally unnecessary. You don't need to check for small intestinal bacterial overgrowth, which is very non-specific testing generally and expensive. Thyroid, if that's all they have is a change in bowel movements, it's almost never thyroid disease, and routinely checking thyroid function tests, you might incidentally pick it up, but it's not going to, treating it almost never makes the symptoms better, and so I wouldn't do it as a consequence of that. And here's her. She's getting ready to eat this lovely croissant. But she goes, "Doctor, I still feel better off gluten. Shouldn't I just stay off this? Couldn't this be gluten sensitivity?" Well, it turns out it's probably not, right? So they did this very elegant study where they took people and they gave the people who were self-diagnosed gluten-sensitive people, and they gave them a bar with fructans, which are these sort of indigestible fruit products, gluten, and then placebo, something that had none of those. And what they found is that only the people that got fructans had a significant change from baseline. The people who got gluten actually got slightly, but not statistically significantly better, but the fructan people got worse. So we think, since so many products contain both of these things together, that gluten is kind of an innocent bystander. So people think about the gluten, and when they avoid it, they're probably avoiding other things too, right? And so that's why they think they have gluten sensitivity. And so we have a thing called the low FODMAP diet. Does anybody know what a FODMAP is? Yeah, okay. So what that means is fermentable oligosaccharides, disaccharides, monosaccharides, and mono, and polyols. And basically these are things in food that are indigestible. They get to the bacteria in the colon and they get fermented to make gas and change some other things that I'll talk about. And all of that creates some GI distress, right? So, they're undigested simple carbs. They increase the amount of bowel water that you get, much like that osmotic laxative I was talking about, polyethylene glycol. They do a lot of the same thing. They draw water. toward them, and they can actually create barrier dysfunction. So you get translocation of bacteria and bacterial byproducts, cause some low-grade inflammation, things like that. And so this is real. It's been well studied in a few randomized controlled trials and decreases symptomatology. So when I put somebody on this, you can Google this and you find a chart like this. And so on the top are things you shouldn't have. These are foods that are high in FODMAPs. And on the bottom are things that you can eat on a low FODMAP diet. And I put somebody on this for 4 to 6 weeks. And then I tell them, after you've done that, look at the top list, find the thing that you miss the most. So if you're an appleophile and you're like, man, I haven't eaten an apple in 6 weeks, I could really go for an apple. Great, have one and see how you feel. And if you feel fine, great, you can eat apples. And then you keep doing that throughout the process until you kind of find things that are your trigger foods, right? That's the right way to do that. And it's important for people, if you're going to put them on this diet, to tell them this diet is not a forever diet. This diet is a month and a half, and then you need to start reintroducing things. Because like all medical interventions, medicine or otherwise, there's good and bad, right? So what are the good? Well, studies have shown this. Most people respond to the diet. They get less bloating, they get less abdominal pain, they have fewer stools. So that's all good, right? They have fewer symptoms. What's the bad? Well, the bad is kind of the long-term consequences of it. So your biome gets simpler when you do this. And we know that a more diverse biome is associated with a lot of health metrics, including decreasing future risk for cancer. So leaving somebody on this diet long-term, we think might increase their risk of cancer. Because it's limited, you're going to have fewer micronutrients, less fiber. It may cost you more. And frankly, it may be equal to some other regular IBS advice, like don't eat fatty foods, avoid lactose, things like that. And so if you're going to try it, only try it for a brief period of time. If you want more information on it, the Monash website, and there's actually an app you can download, super helpful. Patients can have it. It helps them navigate. Like, they're not going to carry that chart around with them probably. So this app, they can be like, is this food on this low FODMAP diet or not? So it really helps them to kind of navigate their lives. Okay, so you tell her that, and she's still not convinced, man. She's like, "What, doctor, why can't I just stay off gluten?" I get what you're saying about the low FODMAP diet. It sounds kind of complicated. And I'm a simple country person. And I said, well, here's the bad, right? So a gluten-free diet is not risk-free, right? So first, I don't know if you guys are aware of this, gluten is delicious. I love gluten. If you're going gluten-free, give all your gluten to me, and I will eat it for you. But people need to sell products, right? And so to make the food taste good, you have to add something to it. Usually that something is sugar, and it's fat. Right? So these foods are usually not healthy. People often gain weight on the gluten-free diet, and being overweight is bad. And you're going to miss some things. So particularly these vitamins and minerals, folate, calcium, fiber, that kind of stuff. It's expensive. I don't know if you ever go through the gluten-free section at a supermarket or stuff, but there's a premium to do this because you have to create these new products and such. And it turns out you have increased heavy metal exposure, probably from rice is probably what this is from. But all these kind of bad elements that you can get in there. So, and it's social impairment. So if you want to go have boredom with your friends and you can't have it, that's kind of a sad day, right? Stuff is delicious. And so this is what you tell her. You may have celiac disease. You might have another gluten, sensitivity, or another food sensitivity, not gluten, like fructans. Or you could have IBS. Okay, so that is it for the talk. Do you want to do questions now, or do you want to go right to his? Or how would you like to?
Are you going to do the interactive one? Are we doing? I thought
we were going to get a case at the very end, right?
Are we doing the interactive later?
Yeah.
Okay.
Okay. Yeah. So does anybody have questions about the two things that? Yes, ma'am.
Okay, hi. I have a question. How important is the psychological part of the patient in IBS?
Yeah, it's critical, right? So if you look around 85 to 90% of people who present to your office with irritable bowel syndrome have either depression or anxiety. And so it's kind of the elephant in the room in many ways. And so I think learning to address that early is important. The rub is how you do it. So if it's the first thing that you say to the patient, then often they feel dismissed. The doctor tells me it's all in my head. They think I'm crazy. So usually I have my very medically first visit, and we talk about all these kind of things we talk about. And then as we get to know each other and our relationship goes, I start to talk about the mind-body connection in a very kind of holistic way. And then some people, I will treat those things myself. I've become comfortable in managing those. Some people, I'll refer them to a behavioral health specialist depending on the severity and their willingness, because some people are willing to have me do those things. And now, actually, one of the things that's happening in the kind of internet era is some of this disruptive technology that allows people to do cognitive behavioral therapy either on apps or they have remote access. So maybe their community doesn't have somebody who does this, but they can access them on the internet. And that's actually, in a couple of trials, been shown to be effective. And so, and a lot of the things they do in CBT, you're self-training, you're changing your worldview and your perspective, and you're learning how to self-soothe and things like that. A common problem in irritable bowel and other functional diseases is what I call catastrophization. So, your belly feels bad now. You don't really remember that it felt exactly like this a year ago. You feel like it's brand new, you feel like it's terrible, and like you might die from it, like you turn everything into an emergency. Regular follow-up helps with that, because it's a cyclical disease. Sometimes when they see you, they won't be in a catastrophe, and you can sort of highlight those past visits as well. So, but that's a great question. It's critically important. Yeah. Sir.
Hi, thank you for the talk. I really enjoyed it. I had a question regarding your common practice, because I know it's very difficult to do the doctor's job when you leave a great part of the treatment to the patient themselves. Mm-hmm. So, for example, you will give the patient a diet that you may think it would work for him or for her, but how sure can you be that the patient is actually taking the diet and the diet is not working, or maybe the patient is not strict enough, or is actually just being untruthful with their doctor?
Yeah, that's a great point, right? So part of that's in developing a therapeutic relationship with the patient. And I assume, I think correctly, that almost nobody does exactly what I tell them to do. If I tell you to take a medicine, you're probably not taking it 100% of the time. And a lot of studies for medicine show if you take 80% of the dose, 80% of the time, you're going to get the effect of the medication, right? So, for example, when I'm taking a history, and I'll use a medication as an example because it's simpler, but I'll get to the diet part. I will ask them, I said, most people miss doses of their medication. How many times in the last month do you think you've missed? I recognize that it's hard. And they'll be like, probably like 6 doses. I mean, they'll tell you an answer. They want to please you, but if you normalize what you're asking about, and that's true if you're taking an alcohol history, a drug history, then it opens the door to communication. So it's really communication, and I tell them, I go, this is a hard diet. Eating out's great, and it's harder to do these kind of things. Like how have you done in holding to this? And if they tell me it was hard and I really didn't do it, okay, then do you think you could, or you think that's something that's just not going to be possible for you? Because if it's not possible, then even if I think it's the most effective thing, I've got to pivot to what they're actually going to do, right? So, Osler said that, caring for patients is about the care of the patient, that individual patient. And so you really have to negotiate. Because what you said, I think, is very wise. I tell them, I'm going to see you 0.5% of the time, maybe. The rest of this, you have to live. And so we have to come to a plan, that you can actually make happen. I think you were next. Yeah.
Thank you. We know as doctors that it's really hard to diagnose about a disease or whatever. I would like to know if we have, for example, the symptoms that are quite the same with the IBS, but we know that there is something else that we can diagnose. I would like to know if someone represents with quite similar symptoms and we think that it is IBS, what else could be with the same symptoms that could lead us to another disease? So, I mean, in general, which other disease should come in our mind that have the same or the similar symptoms like IBS?
Right, so that's a good question. I'm going to answer a couple of implied questions that you had there, just like medical philosophy kind of stuff. One, I think when we're starting off in medicine, we're very concerned with being right. Right, you take a test, they want you to have, there's only one answer, like A through D, whatever, there's a right answer. And that's sort of true in real practice too. But even the most expert diagnosticians, based on a lot of the work that's been done in this field, are 85% right. That's if you're the best you're wrong 15% of the time. And close clinical follow-up covers over a multitude of sins, right? So, the patient can come back to you because, like I said, most of the time you're right. 95%. That means 5% of the time for IBS, you're going to be incorrect, but usually that incorrectness reveals itself over time. And the likelihood that you're going to make a fatal error, that somebody's going to come in with what sounds like IBS, I'm going to be wrong, it's not IBS, and they're going to die before they can see me again, that essentially never happens, right? And so I think, the reason you get trained to do a review of systems as a medical student is because that's where you're going to catch this other stuff. Now, what particular review of systems do I do for somebody with IBS? I ask about rashes and headache and flushing and joint problems and things like that. Because there are things like mastocytosis, right? Or eosinophilic disease of the GI tract, or IPSID, like they're immunological conditions. We can do this. C1 esterase deficiency can do this. But those things all have other symptoms that go along with it, right? They don't just have this. And so, I diagnose somebody. Have you guys heard of alpha-gal? Have you heard of this? I don't actually know if it exists here because I don't know if the tick vector. So there is a disease where if a Lone Star tick bites you, you can get a sensitivity to alpha-galactosidase and be allergic to meat. Yeah, that's terrifying. Nobody screamed. I'm amazed. Like I heard that, I think I screamed. I could be allergic to meat. That could happen. And I had a patient with that, but that has very IBS-like symptoms, but you also get a rash. And so the guy sent me a picture of him on his toilet with a rash. And I was like, one, never send me nude pics again. But two, yeah, I know what you have. And so I sent him to my friend to get tested, who was an immunologist, and yes, that's what he had. And so, yeah, but usually you catch that up if you take a careful history and you follow the patient over time. So I heard it once said that the difference between a good physician and a great physician is the ability to manage clinical uncertainty. So you're often going to want to know 100%. Very little is known 100%. In medicine, or in life probably, but in medicine particularly. Tim.
Patrick, can you teach me what other symptoms accompany pelvic floor dysfunction besides constipation, if there are any?
Urinary retention. You can also see. You can get dyspareunia with it. If you have pelvic floor spasm and stuff during intercourse, you can get that. So those can commingle. Yeah. The other thing I didn't really talk about is sometimes these can be associated with trauma, particularly sexual trauma, and so taking a history, to get at that element of it is also important.
Thank you.
Yeah. Right. Thank you.
Great. Thank you so much. And if you'd like to stand up and stretch or loosen your body a little bit, we're going to take a break for just a minute. Let them switch computer things, and while Dr. Paul Halverson is getting ready, I just want to learn a little bit about the audience. Is everybody from Pristina? If you're from Pristina, can you raise your hand? Oh, so many not. Oh, wow, cool. So it's a blend. Nice. And are most of you 4th, 5th, 6th, or graduates? How many are graduate doctors already? Oh, congratulations. Well, and the few of you that raised your hands who are graduates, can you tell me what specialization you would like to have? So I'll start in the back. Specialization? Pomology. Pomology, and yes, sir? In the way back? Nephrology. Does anybody want to be a gastroenterologist? Yeah! There you go. You guys have a major jump on poo. Next one. Does anybody want to be rheumatologist? Just out of curiosity. Okay, so we have a couple for Paul. That's wonderful. And Dr. Paul Halverson has come all the way from Wisconsin in the United States, and he has over 40 years of experience as a clinical rheumatologist, teacher, and just overall great guy, and he's going to take over the stage next and do a little bit of work about rheumatology. So after you, Dr. Paul.
Thank you, Dr. Tim. So I have to apologize to begin with because I'm not half as funny as Dr. Patrick here. And I think in general, when I think about arthritis and things, maybe it's a little boring in some ways. It's not too exciting, but there's a lot to learn. And especially when you see patients, and especially when you see older patients, that at least 30% of patients have some kinds of joint problems, and sometimes it's rather difficult to decide what to do. So some of this will be a little bit basic. I'm going to present 3 cases, and then After those 3 cases, when we have the part that is more interactive, then I have 3 more cases which are sort of variations, and then you will have to sort of, I guess, decide what to do with these cases. So the first one is a 72-year-old woman. She has a long history of hand pain and stiffness, and this is worse when she is active. It has been present for many years. She noticed that her fingers have become kind of knobby. We call it knobby. Her rings don't fit her anymore. She used to work in an office as a secretary. She likes to do gardening and work outside. She also complains of pain when climbing stairs and gardening as well because her knees are bothering her. So this is a picture of what the joints would look like. The changes are, I think that you can see, right out here in these joints, the distal interphalangeal joints, and then the proximal interphalangeal joints. So what do you think the diagnosis is? Did I already reveal it? Yes. Well, it doesn't really matter because this is the part that I'm giving you anyways. But just, I mean, I hope that that you have thought about it a little bit. But if you have even familiarity with older people in your family and the grandmothers, you look at their hands and they're sort of changed. And what is it? It's osteoarthritis, right? So this is one of the most common things that happens. It is most common probably to see it in these DIP joints and PIP joints, but I do want to mention that right down here at the base of the thumb, that could be described as the first metacarpal joint. It could also be called the trapezio-metacarpal joint. But if you said, well, it's the joint right there at the base of the thumb, I would know what you're talking about. But many older people will, in addition to these joints in the fingers, will develop a change in which there is enlargement of this area and it sort of becomes squared off. And it actually is more likely to become much more painful than the other joints in the hands. So why are these joints enlarging? What's going on? No, it's not inflammation. We call osteoarthritis non-inflammatory. And the reason is that if we compare it to a disease like, say, rheumatoid arthritis, and we take fluid out where we can see there's increased white cells in the fluid, and if we get the inflammatory markers, SED rate, CRP, in osteoarthritis, they should be normal. If it's abnormal, it's not from osteoarthritis. So what's causing these changes in the joints?
Maybe it's the position. She was a secretary.
Well, I mean, but what happened? Something happened, yes.
The cartilage, like.
Since she liked to do gardening, and she worked as a secretary, as my friend said, the cartilage was eroded, so the bone gradually gets exposed underneath the cartilage. Yes. So there is not much lubrication, yeah. So
that is one thing that's going on.
Yeah, so then the bone would get exposed and her deposition of fibers, I guess. And that's why they would become enlarged.
Okay, but is this stuff that is around the joints, it's bone, right?
Yeah.
So there has been new bone that has grown around the joint. This is a reaction of osteoarthritis.
To mechanic trauma, yeah.
Well, it could be part of it as well. But whether the person inherited genes that made them get this osteoarthritis, so it was going to happen anyways, or they did things that were traumatic to the joint, it was going to happen. And so the new bone forms around the edge of a joint. It's like a ridge. We call them osteophytes. You've heard that term, I think, right? So these are osteophytes. And why do they form? Well, honestly, we don't really know. I mean, they may actually be somewhat of a protective mechanism that the body has to try and prevent more motion in the joint, but that's more speculative. But anyway, that's one of the main findings to help you know, so that if you saw something in that, somebody it's osteoarthritis. Sometimes people forget that it's also at the base of the thumbs. One of the places that it should not be is in the metacarpal phalangeal joints. Okay? So we generally think of it as a wear and tear phenomenon. I tell that to my patients because it's the easiest thing to understand. You're just wearing out. And it's not completely true because there are other reasons that people get this condition. But it's the most easy for people to understand. Yeah, okay, I got that one. So it affects mostly the hands, the weight-bearing joints, and the back. I'm not going to talk about the back so much, although again, in a clinic, you would be perhaps seeing many people who have back pain. And some part of that, and maybe most of them, might be from osteoarthritic changes, also called degenerative joint disease, degenerative disc changes, all of this going on in the back, the most common thing. Unfortunately, the treatment is mostly symptomatic. In other words, we do not have any magic medications that we can use to give people that will stop this process, reverse the process, or even somehow make it really a lot better. We can talk about that later if you would like to. If someone has severe joint damage, the main thing we have to offer them is surgery. I mean, we may do some things along the line. Maybe we'll give them cortisone injections. Maybe we will send them to a physical therapist. But again, it's rather limited. So this is just a cartoon, more or less, to tell you what is going on in osteoarthritis. And if you look on the left-hand side, that you can see that the cartilage that lines the bone ends is actually starting to split. So these are little fissures, these are little cracks in the cartilage. And as time goes on, you get to the middle one, and they enlarge, and so much so that pieces of cartilage are going to break off and just disappear. Is the body able to repair this? No, the body will not repair it. So finally it goes out to the right panel, and you can see that there is very little of the cartilage left. And when that does leave bone on bone, as it was described, this does not move well as a joint. And so either the patient has to suffer with it, leave it not moving, or possibly get surgery. But you can see also at the same time that they've tried to represent on the corners there that there is new bone formation, which are the osteophytes. We sometimes call them spurs, mostly because if you have an x-ray of someone who has this and you look at the joint, it sort of looks like a little spur sticking off that. But that's, in a sense, an illusion because it's only as it's cut through to get the x-ray, and really the osteophyte goes around, a ring around the joint, leaving that enlargement. And this is what it would look like on x-ray. These are knees, weight-bearing joints, and the most typical findings would be the joint space narrowing. And you can see that on the right-hand side that the joint space is pretty much gone in the lateral compartment, and the joint space is still pretty much preserved in the medial compartment. Can you see that? Is that clear? Or do I need to point it out? This is sensitive to touching the arrows on here. This is kind of more symmetric, asymmetric in terms of not involving necessarily the whole joint, and one side may be more involved than the other. And that space there, of course, I mean, we talk about it being a joint space, but actually it's really a cartilage space. So what's in there is cartilage, and so that's why I can say that in the lateral compartment, the cartilage is worn away because that cartilage space is gone. The other findings on there that are very typical would be what we call sclerosis. That is the whitening of the bone. It's a reaction in the bone around there. And then the last thing is the presence of the osteophytes. And I think it probably is best seen, right?
Excuse me, could I ask a question?
Yes, of course.
As you mentioned, these are not symmetrical, so...
So within one joint.
Exactly. Do they have to be bilateral or only unilateral?
It can be bilateral or unilateral.
Okay, so they don't start at the same time? They don't have to be on both sides?
It doesn't have to. It can be or it doesn't have to be. It comes both ways.
Okay, not even on the same joints throughout the body?
Not necessarily the same joints.
Okay. Thank you.
So on the knee, which would be the right knee, on the inside, you can see a slight enlargement. You have to use your imagination. You have to use your imagination, but this right here is an osteophyte, and it doesn't look exactly like a spur in this, but you could potentially call it a spur on the joint. Okay? So this is now the second case. Now we're talking about a 56-year-old woman. And 6 months earlier, she gives a history of having swelling and pain in the small joints of her hands and her knees. Now she has stiffness in the morning lasting 2 to 3 hours. Her past medical history includes hypertension, depression, and anxiety, but she is only taking the medications lisinopril with hydrochlorothiazide and ibuprofen up to 600 milligrams 3 times a day. So this is what her hand looks like. The other hand looks this way too. So any thoughts of what this is? Yes?
So it cannot be due to heart disease because then it would be the ankle swelling.
If the person has heart failure?
So it doesn't have much,
edema, yes?
Yeah, so I'm suspecting it doesn't have much to do with the history of hypertension that she is taking medicine for.
Correct.
I suspect it's rheumatoid arthritis because it's the articulations here.
Yes.
So that would be my suspected diagnosis. And also we know that rheumatoid arthritis is more severe in the first hours of the morning, and then during the day it starts to alleviate and the edema starts to go away, as opposed to osteoarthritis.
Okay, I think that
I'm just suspecting.
I'm not sure quite so much about the last thing that you said. Yes, it is worse in the morning in that people have stiffness, and so that they have trouble moving the hands or moving around. And as the time goes by, they may be able to move them better. But I don't think that the appearance would change. I don't think that the swelling actually changes very much. I think it stays more or less constant through the day. So this is rheumatoid arthritis. Does anyone have a question about why this might or might not be rheumatoid arthritis? Okay, so this one affects the metacarpal phalangeal joints, the proximal interphalangeal joints or PIP joints, but not the distal interphalangeal joints. So if you have someone with the distal interphalangeal joints with the changes, that is not going to be rheumatoid arthritis. That part at least. So this is an immunologically based inflammatory arthritis. So we can do some kinds of immune and inflammatory testing. What tests do we order? Okay, rheumatoid factors, 1. I'm sorry? ANCA. And ANCA is a test that is used for this thing called Wegener's granulomatosis, so a form of vasculitis typically. There's other vasculitis as well. So ANCA should not be positive in rheumatoid arthritis. In fact, if it was positive, it would be very confusing. So you'd have difficulty with it.
Could it be anti-citrulline?
Anti-citrulline? Okay, anti-citrulinated peptide. Okay, cyclic. And so those are called ACPA. Okay? I mean, they've been there. So that would be another test we could order. What else should we order?
Antibody?
Yeah, she said the rheumatoid factor. Yes, that is basically the anti-rheumatoid. Okay. What else would we like to have for other tests?
Culture test?
A culture.
Yes.
For what? Is that related to rheumatoid arthritis? I think it's related to rheumatic fever, right?
Yes, exactly. But it's caused by.
That's caused by strep. But the thing that is called rheumatoid arthritis probably is not related to strep. Rheumatic fever would be a completely different disease, even though they have kind of the same name. But it's really different. So I wouldn't order an infection test. Yes? Okay, anti-CCP is the same one as the circulated peptide, also called ACPA. So that means that's exactly the same. Yes?
C-reactive protein.
Okay, C-reactive protein, why? Because of inflammation, and so it will pick up any other tests to do?
Yes, sedimentation rate.
What? Sedimentation rate. So 2 tests for inflammation, and then two tests that are not exactly the same, but are also detecting rheumatoid arthritis. Now, I mean, depending upon where I was and what the situation, I mean, I might order some other tests too, but we could maybe talk about that a little bit later. So it is associated with rheumatoid factor and the ACPAs. The interesting thing about it is that sometimes it seems difficult to sort of be aware or be sensitive, feel the changes in those joints and fingers, particularly that are inflammatory. So I said I've been doing this for 40 years, and many times when I've had students in clinics and I have a patient with rheumatoid arthritis and I show them the patient and they feel the joints, they try and even squeeze the joints, and many times they're not sure. But there is a sensation, it's sort of puffy around the joints, and then if you press on it, it hurts. And that kind of means inflammation in the joints, called synovitis, inflammation of synovium. How many of you have seen a patient with rheumatoid arthritis? So just a few, really. But were you able to, those of you who have, was it easy to feel the inflammation in the joints, or was it sort of hard to feel? Was it something that was easy, or was it not so easy?
You actually didn't examine it.
Oh, I see. You saw the patient, right? That's a good start.
This is the student section of the
Okay. You just see that. Well, for people who have arthritis and joint problems, being able to touch them and examine the joints is, I think, it's critically important. In fact, we have many tools that we can use, lab tests, x-ray, but in the case of arthritis, your hands are one of your best tools. So if you can feel the changes in them, you will have a much better feeling about understanding what's going on. Because sometimes the blood tests lie, sad to say. So there are many things that have been done for people with rheumatoid arthritis. Many treatments have been developed. In fact, in terms of almost miracles in medicine, in the past 20 years, medications have become available that will stop rheumatoid arthritis from completely destroying the joints in the body. So it's kind of an amazing story. This gives you a little cartoon again of what is going on and showing you that cells, inflammatory cells, are attracted, for reasons we do not know, to the joint, the inside of the joint called the synovium. And so that's the red tissue, but as time goes by, this expands, more tissues come in, and I hope that you can see then that where there is joint and cartilage, that now it is being replaced by this inflammatory tissue. So the inflammatory tissue erodes it away, it just eats into it, and then in that process, it damages the joint, again, removing the cartilage, making the joint unstable and not usable. And this shows you some of these erosions. This is the same person having an x-ray of a finger joint over time. On the left side is normal, and the right side you can see is very abnormal with the erosion around the joint, and also some loss of the joint space. In the middle one, if you look it's hard to see probably, you can't see it very well, but the white line of the joint, or the bone, which is called the cortex, is now not so easily seen. And that is the area that will eventually just collapse and form the erosion. And these are associated with characteristic deformities. This is called, anybody? This is not really a swan neck. This is called ulnar deviation. But this one is a swan neck, okay? So this one is, it's not so good, but this one is even worse. It's kind of like the reverse of a swan neck. Okay, so that's enough for rheumatoid arthritis. So now we'll switch gears and go to another case. Here's a 45-year-old man. He has a painful, swollen big toe, first toe for 3 days. He denies any fevers, no other past history like this, no recent illness. And if you examine him and you see that he has a swollen big first toe or first toe metatarsal joint, and it looks like this. So I hear people talking. That's good. Yes, uric acid. I don't know what you call it. We call it gout. So it is uric acid deposition into the joint. Okay, and so this is not, the only joint that it can affect, but probably the most common one. And it makes the joint appear quite swollen, painful, red. If you touched it, it would be warm, and if you were to do very much with it, the patient would not like it because it would hurt too much. So in this case, the patient's kidney function was normal, but he had a uric acid in our system, 8.4 milligram per deciliter, which is increased above about 7.2, which would be the normal, okay? So that would go along with this patient having gout. Now, of course, there are other reasons that people may have elevated uric acid, especially if the kidney function is not normal, or even taking thiazide diuretics. And so just to get an abnormal test without having the compatible arthritis with it does not make the diagnosis of gout. But it is caused by precipitation of uric acid forming crystals in joints. They may sometimes also deposit in other tissues, sometimes in the elbows, in the ears, other places that the crystals may deposit as well. Those are called tophi. Those don't usually hurt or anything, they are just there. And if you had the opportunity to take some of the fluid from a joint that was inflamed and put it in a microscope that has polarization capacity, then you would see a needle-shaped crystal like this one, and inside a white blood cell, and that would be an absolute diagnosis for gout. So what do? We recommend treating the attack. We could use a high dose of a non-steroidal drug. Ibuprofen, naproxen diclofenac, I've heard is very popular in the Balkans. But then, depending upon if there were already some attacks, then to initiate treatment to prevent future attacks. So how could we treat future attacks? By lowering the uric acid, right? With what? Diet? People have tried that, but it actually doesn't work very well. You can't lower it enough typically. Yes? Allopurinol would be the most common way to lower it. And one of the problems that we have sometimes is that we give a medication like allopurinol, typically something like 300 milligrams per day, and then sometimes the patient comes back and they have more attacks of gout. One of the problems is that sometimes that will be insufficient to lower the uric acid enough to make the attacks of gout stop. So the target or the goal for uric acid would be less than 6 milligrams per deciliter, but in other words, lowering it at least well into the normal range, not just to the right upper limit of normal or a little above, not good enough. It has to go lower than that, and if that happens, then the attacks of gout should stop. That means you would have to come back and ask the patient to have another check to see if the uric acid was low enough, and if it wasn't low enough, then you have to change the medication to get it to be low enough. This is a problem all around the world to get people to treat gout enough to make sure that it goes away, because it should be treatable. Okay, so I'm going to stop here, and we can figure out how to do this. Do you want to do, I can do these other cases first, or we can switch and have you do your GI case first?
Well, I'm not sure how you want to do this. Yeah.
Do these cases first? Okay.
Okay.
So this is the case where you have to decide what to do now.
So what I'll do is I'll moderate.
Okay,
I'll be the rounding physician. You'll present the case, and then I'll get the
Very
information
good.
for these cases.
Excellent.
Be all right?
One of your
Okay.
special-
Great. Fantastic.
Okay. So this is an old woman now, 75 years old, and complaining of pain in her hands and wrists for years, but it is getting worse. She has taken what we call over-the-counter, in other words, you can buy them in the store, the diclofenac and things like that, but only limited benefit. She does also have hypertension, back pain, and she takes lisinopril. She has a family history that is positive for osteoarthritis. And when you examine her, you see that her PIP and DIP joints have bony heart enlargement to what I would say a moderate degree, and several of these joints are going off to the sides. In other words, I would say they're angulated, they're going at an angle. But several of the PIP and DIP joints are tender to palpation. And if you look at her, that you can see that, you know, she has quite a bit of changes. And I can't probably go into too far, but if I had to pick some joints that I think might be tender, or you pressed on them, they might be tender. I would think this one might be tender, this one might be tender, maybe one or two of these too. Without being able to press on it and feel it, you can't tell. But, I mean, some of them are tender, and so this is something going on there. So we talked about the lab tests. We could get the rheumatoid factor, CCP or ACPA, ESR and CRP normal. And in this case, also another test, the ANA for lupus and other related things was ordered. The x-rays show some osteophytes and sclerosis and in most of the PIP and DIP joints, with irregularity of the joint margins and cystic changes, again, just changes mostly of osteoarthritis. So the question is something else going on? What else could we do? Okay?
Very good. So what I'll do is from your side, you raise your hand if you have some things you'd like to order, maybe something you'd like to add to the differential diagnosis, maybe something you need from the history that was not presented by Dr. Paul. So yes, sir, in the back.
I would like to know if the metacarpal and metaphalangeal joints are swollen too or not.
They are not.
Other questions, other tests you'd like to have? Review of systems. I'll just ask, any chills, fevers, weight loss?
No.
Any other joints involved besides the knees, beside the hands?
There's some changes in the feet, but they are not bothering her that much.
Very good. Yes, sir.
Is the pain persistent, or it gradually with time gets easier?
Well, I think that I would say that many times, especially in the morning, both patients with osteoarthritis and rheumatoid arthritis typically have more pain. The people who have osteoarthritis, the stiffness is less. And so it usually doesn't last more than 1/2 hour, but if they have active rheumatoid arthritis, then usually it is going on an hour or more. There's a question.
Oh, yes. Mm-hmm.
Does anti-inflammatory drugs work in this case?
I think I gave in the history that they help somewhat.
Very good. And are we allowed to get the results of your testing?
What's that?
The rheumatoid factor was negative?
Yes.
CCP negative,
yeah,
ANA
all
negative.
of these negative.
Very good. So the differential diagnosis, or what's in your mind as what the problem may be? Yes, sir.
So I was thinking osteoarthritis with rheumatoid arthritis, but since there was no other swelling of other joints in the hands, I was thinking more towards osteoarthritis.
How many believe this is osteoarthritis? Good. How many believe that it's rheumatoid arthritis? How many believe that it's both? Okay, after you, sir.
Okay, so even though most patients with osteoarthritis do not have too much pain in these joints in their hands, but occasionally there are patients who have some more pain and swelling in their hands. And so this is osteoarthritis with some local inflammation. Not enough to make the inflammatory markers ever become abnormal, but in about 5% of all cases with osteoarthritis, there is more damage and some inflammation. It may be episodic, it may be part of the development of the process, but they really do have a lot more trouble. And so that means that treatment is difficult, and it doesn't necessarily respond to other things that rheumatoid arthritis does. So, but there is at least 1 or 2 studies that show that maybe giving out trial of hydroxychloroquine or chloroquine, I don't know, Rezoquine, I don't know if you know those drugs for anti-malarial drugs, will actually help to some degree. Not make it go away, but just reduce the pain. But even that has not been adequate. We have tried medications like methotrexate without much success. And some people have even recommended maybe to try like prednisolone, 10 milligrams a day for 2 weeks and then stop. And then the patient probably is going to do a little better during that time. And but you don't restart it again unless the pain gets bad. And the reason is that you don't want to expose the patient to long-term prednisone, cortisone, things like that, because they will develop side effects and they will have more problems. But as an intermittent treatment that would be done once in a while, sometimes for bad times, then it might actually be helpful. Okay?
And just one last question to you all. Should this patient continue to take ibuprofen or ketorolac or the non-steroidal anti-inflammatories every day? Yes? If so, what's the risk?
I don't think they are supposed to take it every day because the inflammation is not as great. And I think it should be done on more painful days because we know inflammation causes cytokines and all the other chemicals that induce pain. So maybe we can indicate that they can take it on the days where their joints are more painful. But I think they have larger risks if they are allowed to use them in a daily basis without having such a huge inflammation source.
Super. And what is that risk? And thus we have Dr. Patrick. So we would call Patrick and say, fix the ulcer that is no
If
good.
I were to ask Dr. Patrick, he'd probably say that he hates those drugs.
They are a mortal enemy. Yeah, I have not prescribed a non-steroidal for anybody.
Okay, so typically what I see done here is that people will, if they are prescribed or recommended to take these medications, will also be given a PPI drug, which will at least partially protect them from the bad effects. And so I think what the way to do it, the idea is the good one, to use it only intermittently, and maybe in the lowest dose possible, but it doesn't mean that they can't absolutely use it, but they shouldn't. It's best if they don't use it all the time, that's for sure.
And my last question is paracetamol effective in any way?
It can help. It can be useful, and that might be something you try. The studies have suggested that the non-steroidals probably give a little bit more benefit. Another route would be, and these are available, to have topical non-steroidal drugs. Have you seen these? Topical, maybe ibuprofen or Voltaren. And again, if the patient can afford those, because I think they are usually more expensive, but I would say that if it was possible, I would recommend to try that and see if it got the same effect, because very little of it is absorbed, so it is generally safer.
Very good. What I'd like to do is mix it up so they're not thinking rheumatologically, so throw on the GI case next, if you can.
That was what I sent you as a Word doc. Is it on here that I can pull it up so people can look at it? The case that I sent? Oh, it's printed. Okay.
Oh, is that it there?
Yeah, so we can do it that way.
Okay,
so,
great.
Very good.
One of the tough things is whenever you see a patient in the ambulance or in the hospital is that if you see them in the cardiology department, you're thinking cardiology. And right, so now you see a GI doctor standing in front of you, so the case is likely to be GI, or if it's Paul, it's rheumatologic. We want you to try and keep your differential diagnosis wide because the patient you're going to see isn't necessarily going to go to the right doctor to start.
So I'm going to give just a moment for these to get passed out, and then I'm going to sort of walk you through. And this is a patient that I've seen on some occasions in my GI clinic, so this is loosely based on that. I probably made it a little more straightforward than it might be. I've given you some things that might be a little bit more challenging to pull out of the patient. And we'll sort of walk through how we approach this. And then what I wanted to do after that actually was either immediately after, or if you wanted to do this next case, I could play the what if game. Like, what if this patient came in and instead of this, he said this? Then what would you think? And sort of go through that way, because it's what is important to sort of dovetail onto this that'd be great. Because what's important, we talked about getting the right answer and how important that seems as a student. So it's less important to me what you think than how you think, right? So if you don't come up with the answer, that's not the most important thing. The most important thing is like, how did you arrive at what you're thinking? Because that's how you're going to get better, is figuring out where you went astray And I think anytime you're trying to think of something, even if somebody walks into your clinic or to the emergency department and they seem like the most obvious textbook case of X, Y, or Z, always ask yourself, if it turns out not to be this, what are the other two top things I think this could be, you know, when they called me 3 days later? Remember that guy who you thought had this? Well, he had X. So this is a 35-year-old guy comes into your clinic. He's complaining of heartburn and trouble swallowing, right? So super common reason that I see people in clinic. He's got trouble not just with solids, but also with liquids. And he notes that for a while now, whenever he goes out with his buddies, he's always the last one to finish eating. You know, he does feel like food gets stuck in his esophagus, and when he does that, he drinks lots of water and sometimes arches his back or even raises his hands up, and he feels like that sometimes helps the food go down. Occasionally, when he's done those things, he goes, "Doc, it's the weirdest thing. It actually feels like a toilet is flushing, like it's just a sudden emptying from my chest into my stomach," and then he feels good again, and he can eat and do whatever. On occasion, he has woken up in the morning and he notices there's like this foamy fluid on his pillow, which is kind of new and weird and disconcerting to him. He has not, thank goodness, lost weight. He has not had melena. He's not had bright red blood coming out of his bottom. And his bowel habits are normal. He's not having diarrhea. He's not having constipation. You know, he has, because of the heartburn component, he's tried taking things over the counter, and that's not really given him any relief. He's an otherwise healthy guy. He's got some seasonal allergies that happen periodically in the spring to things like grasses and ragweed, but otherwise is okay. Had an appendectomy as a child. He played soccer growing up, and he had a bad knee, so he's had a knee arthroscopy, but that's really it. Periodically, he takes fexofenadine, which is Allegra. It's an anti-allergy medication in the spring. He takes a men's multivitamin because he wants to be healthy. And he takes, calcium carbonate, which is the over-the-counter kind of Tums or similar medication for the heartburn. He doesn't have any allergies. And I don't remember if I gave him a family history or not. Let me scroll down and see. His dad has hypertension. His mom had breast cancer at 61. And so the first question is really, what is your, and I say ordered differential, like what do you think could be going on that would explain these symptoms? So, yeah, and if you feel like, and I don't know if you want to moderate, if you feel like you need more information, feel free to ask those questions too. Like before you get to a differential, feel free to ask other things. You think it's achalasia? Okay. I'm sorry, what is it? Diverticulosis? Like a diverticulum of the colon or a diverticulum of the esophagus? Esophagus. You think it could be an esophageal diverticulum? Okay. Yeah, thyroid is normal to palpation. Yeah. Have not done any of that. He's in my clinic, so I'm deciding on what to do yet. So you would like to get an X-ray? Is that? Yeah. Well, let's hold on the what to do next and kind of go through.
Can I ask you something?
Yes.
When the patient clinically reported symptoms, did he have firstly difficulty swallowing solid foods, and then they progressed to difficulty swallowing fluids?
Yeah, so why do you ask?
If it is progressive, then it would indicate a tumor mass. Because it firstly starts with liquids, and then it progresses to difficulty swallowing with solids and liquids. You're saying for tumor, you think it would go solids, then liquids? Is that what you're saying? Just to make sure I'm clear. Yeah, so I agree with that. So in his case, he says they kind of started at the same time. Yeah, he felt like liquids and solids. He's had trouble swallowing both for the duration of his difficulty swallowing. So you think he's got, you're saying, now you're giving me a differential, you think this could be reflux and he's got a complication of reflux disease? Is that, okay. Could it be a hernia at the stomach?
Yeah, like a hiatal hernia? Okay, we'll keep that on the list. And then we'll talk about, we'll sort of order these things. We'll ask the group kind of what you think your top differential is, and then we'll talk about why. Like, what are the elements of this history? Because those are all things that can cause some level of difficulty swallowing in different ways. And we'll talk about how we sort that out at the bedside. And then what tests to do next. So anybody else have either other historical elements you'd like or other things you'd like to add to the differential?
Was the foamy fluid tested?
No, he did not bring that in. Yeah. He took a photograph for me. and showed me. People like to photograph stuff and then show me. But that didn't happen. What would you have tested it for if you had brought it in?
The enzymes.
The enzymes. Help me out.
We went through the entire GI tract, so it will work. Was just the question.
Yeah, no, I mean, it's reasonable. I don't know, I've not know that I've ever tested anything for that. I imagine it would be rich in amylase, probably, like salivary amylase is probably what it would be rich in if I tested. Okay, good. And so we've heard achalasia, we've heard, maybe a peptic stricture related to GERD, something related to a hiatal hernia, or maybe a cancer. This could be a young guy. And I've seen malignancies causing dysphagia down to 22, I think is the youngest I've seen, so it can happen even to young people. Should always be in the back of your mind. So who would put achalasia as their top thing on the diagnosis? Okay, so about a quarter of people. How about like peptic stricture, GERD-related illness? So a couple of those. All right, how about cancer? A mass of some sort, so a benign mass, so about a quarter of people. Here, okay. How about anatomic stuff like a hernia or those kinds of things? So, okay. All right, so that is number one. Like that would be your number one thing. Okay. All right, so it seemed like achalasia and cancer were the two top vote getters. How would you determine the difference historically? What would lean you one way or the other? Like, are there certain elements of this guy's history that make you think more one or the other?
I would ask him if he has history of alcohol intake or smoking.
Okay.
Very hot fluids, we know that they cause esophageal squamous carcinoma.
Yeah.
And also if he has frequent vomiting, that would cause tearing of the lower third of the esophagus.
So like a Boerhaave syndrome, that would present differently. That's usually an acute presentation that is, not a
That would
subacute.
indicate that he takes alcohol, so.
Yeah, almost all of them.
Yeah, so that would give me the information that he takes alcohol, because probably he would refuse to tell me the details of his alcoholism.
Right, that would be, people will usually minimize their alcohol use, for sure. But I think you're right that those are all risk factors, along with like cot and other beetle nut chewing, depending on what part of the world you're in.
He is Indian. It would increase the risk, I think, because it's more common in that.
You mean Indian subcontinent?
Yeah.
Yeah, actually the Maasai tribe in Africa, in Kenya actually probably has the highest risk of anybody, probably because of exposures that they're getting. But I mean, so all of those are risk factors. So understanding risk is important, for sure.
I think we should look at his age also. He's 36 years old, so achalasia is a very, it's not very common to happen in that age,
Do you think it's more common that
younger ages?
You think a younger person would get achalasia and present with it?
Yes.
Okay. Yeah, I mean, certainly you can get presentation younger. It's not uncommon that somebody his age would present with achalasia. 20s and 30s would not be an uncommon time for people to present. Okay. It would kind of be uncommon for cancer. Yeah, not impossible, but if you had to say likelihood, like when is their peak risk of getting this, your cancer risk comes much later, even if you drink and smoke and stuff like that. Typically, cancer doesn't come in your 30s. I've seen it. Actually, the first diagnosis of esophageal cancer I ever made was a 38-year-old woman, which both of those things are rare. So it can happen. But achalasia is not uncommon. Yeah. What about the nature of his symptoms? Does having like liquid dysphagia and solid dysphagia present sort of simultaneously, lean you toward one or the other?
It's very typical for achalasia to have from the start dysphagia both for liquids and solid.
Yeah, it's kind of the sine qua non of achalasia, actually. Yeah, so or any movement disorder of the esophagus tends to have liquid symptoms early. And so what you described was a perfect description of cancer. So I remember the first, as a medical student, actually, what I gave you was the first cancer I saw as a gastroenterologist. As a student, I saw a squamous cell, and he was classic, like, first I couldn't eat, and then I couldn't drink my wine, and then I knew I was in trouble. Right? When he couldn't drink wine anymore, then he came to the doctor. So it's that progressive solid to liquid dysphagia for cancer. What about the things he does to make things better? Yes. So you say yes. Yes, that it helps you with the differential?
Yes.
Yeah, so what does it make you think of?
Rising the pressure to make it go down.
Right, yeah, it gives you the positive interthoracic pressure and pushes things down, right? Which is, again, something that you can't overcome a mechanical obstruction by doing that, but you can overcome kind of this neurologic dysfunction, this failure to relax. So this is a very classic achalasia case, right? So if you were going to diagnose it, how do you diagnose it? That's what I think at the bedside, right? But I still have to prove it. And so how do you prove it? So X-ray, what kind of X-ray? Yeah, like a barium swab or something like that. Yeah, yeah. And what do you see? Do you know like what it looks like? There's a standard description of it, at least in the U.S. we use a standard description. Kind of looks like an animal. You say like a dog? Like a dog. Like a duck. Yeah, it's a bird's beak. Is what we say. Yeah. More like a seed-eating bird, probably, like where it's a point, because it really narrows down to like a really narrow point. So you see a bird's beak. It looks like the bird is standing on their head and drinking upside down. Is kind of what it looks like in achalasia. So that's a good thing. Somebody said manometry. Yeah, that's right. So manometry is pressure testing of the esophagus. And so you see, does anybody know what the two things you would see on manometry? This is a super high level question. So if you don't know, that's cool. If you know, I'll definitely accept the answer. So yeah, so there's, achalasia, do you know what achalasia means? Right, failure to relax. So that's one of the things you see, right? So your lower esophageal sphincter doesn't relax. But the other thing that you see is what's called aperistalsis. So there's no coordinated contraction going down the esophagus. It's not that it doesn't squeeze. In fact, sometimes it can squeeze very hard. There's a thing called type 3 achalasia or spastic achalasia, where it squeezes hard and it hurts, but it squeezes all together, right? And that doesn't do anything good for you, right? It doesn't do anything. So they have aperistalsis and they have failure to relax. So you have to have the failure to relax, because if all you have is aperistalsis, you could have scleroderma or something like that, which is also terrible for your esophagus. And then the other thing we usually do is endoscopy. And the reason isn't because I can diagnose achalasia on endoscopy, it's because I can diagnose things which mimic achalasia, what we call pseudo-achalasia, like an early tumor or something. Particularly metastatic tumor, like breast cancer. I don't like it. It can go anywhere at once. And one of the places it can go is like sub-epithelially, under the surface in there. I've seen a breast cancer do that twice, called pseudo-achalasia. So you have to be careful with that. And then what do we do? So we make our diagnosis using a combination of imaging and manometry. And then how do we treat that? Okay, you said surgery. Okay, so surgery is definitely an option, and we'll talk about that. Are there other options for treatment? Use of medication. Okay. Yeah, it's interesting. Those work for things like spasm and things, and it's been tried in achalasia. It turns out we're not good at medically getting the esophagus to relax at the bottom and contract at the top. It's just not. It'd be great if somebody invented one. We really don't have a good medication for people, unless you mean injecting medication in the esophagus, and that is not true. Botox, right? You can inject Botox into the bottom. Yeah. And then what about, is there anything endoscopically that I can do to treat it? So surgery is an option. Yep. Stents are an interesting concept. The problem with stents is they don't last long enough, right? So temporarily a stent would fix the problem of relaxation, but often when this guy's, God willing, he's going to live a long time, and so he couldn't live a long time with a stent because it would overgrow with tissue and things like that. So it would be a temporizing thing, but it wouldn't be a long-term solution for him. Yeah. Any other things you could do? So, and it's okay if you don't. Yeah, dilation. So we have a special kind of dilator. We call it a bag dilation, because literally it used to be people hand sewing bags together to a specified diameter. This is before my time, but that was originally where it was. And so you stretch the esophagus to like 30 millimeters, 35, 40 millimeters. You have to break the muscle of the esophagus for this to work. So, about a 1% chance of puncturing the esophagus by doing that. It's not for the faint of heart, but it does work. It doesn't work in the young super well, because just like you could probably get up and go play, a football match, run as fast as you wanted to, even if you hadn't been in shape, you're not going to rip your hamstring in half. You get to be my age or Dr. Tim's age or something, like there's consequences. Your muscles break more easily, right? And it's true in your esophagus too. So I can take a 70-year-old achalasia, do a balloon dilation, do a bag dilation, that muscle's going to crack, they're going to do great. This guy's going to laugh at a balloon. His muscles are going to stretch, they're going to go back down, and he's going, what else you got, Doc? So you got to do something more for him. So surgery is an option. Does anybody know what surgery? A Heller myotomy. Yeah, that's right. So you do a Heller myotomy where they go in either transabdominally or transthoracically, usually transabdominally, and they will dissect through and cut the muscles down there. You know, not through and through, but enough to weaken them. We can do the same thing endoscopically with what's called a POEM procedure. So we go down, we inject a fluid cushion between the lining of the esophagus and the deeper muscular layers. We then, make an incision, drive the scope down in between the lining and the other, go down to the muscles, cut the muscles, come back, and either sew or staple that shut. So it takes like 45 minutes to do. The patient goes home the same day. So it's a lot, and that works for some kinds of achalasia, but not all kinds of achalasia. Yeah, so good. So that's achalasia, and then you have another case. Awesome.
Okay. So can you switch back to?
How's your presentation?
That's my presentation, right? Okay, very good. Thank you. Okay, now we have to switch back to using, another part of our brain, perhaps. But so here's a 45-year-old man, and he's complaining of left foot pain and ankle pain for 6 days and not getting better. And again, also typical, has some hypertension, taking the hydrochlorothiazide, but he does have a little bit of renal disease as well. And this is what you see. So let's see, I didn't fix that really. So this is, I didn't do this quite right because I gave you the answer here. So this is, it doesn't, when he has pain in his foot, it sounds like gout, right? But if he had pain in his ankle as well, would that sound like gout? No, except that for people who have gout, sometimes they will change and go from a single joint, because the differential diagnosis of single joint arthritis is most commonly gout or something called pseudo gout. Does everyone know what pseudo gout is? No? So that is associated with calcium pyrophosphate crystal deposition. So it's a different chemical that will also crystallize in the joints, usually more in the big joints, like in the knee most commonly, but also in the wrist, shoulders. And so that one could be confused with it. In fact, for many years, they were thought to be the same thing until people were able finally to identify the two separate crystals. And the one called calcium pyrophosphate occurs because crystals form in the cartilage, and then they get released, and an attack occurs. But why they form in the cartilage, we can't say for sure. And we can't make them go away like we could make crystals go away with uric acid. So this can be confusing sometimes, because if a patient has joints that are not the usual ones we think of as gout, then we might not think of as gout. So if we see swelling in the finger joints of the hands, and we're thinking, well, maybe that doesn't look like usual gout, but if this person has had a history of gout, and then starts to develop more joints, much more likely to be something like polyarticular gout rather than to be something like rheumatoid arthritis. So gout usually occurs in a single joints, but gout attacks can occur in multiple joints at one time. Could involve any joint, hands, knees, even back joints have been involved with gout. And of course, to have someone who has severe back pain, gout is not going to be the first thing that comes to your mind, so you'd have to think of other things. So we'll just go to this last case, which is case 6, another case of hand pain, a 66-year-old woman who has had hand pain for about 10 years. She went to a doctor who gave her a diagnosis of osteoarthritis, but her hands have become more painful. She has a past history of hypothyroidism and hypertension, and you look at her hands, and you can see a lot of changes in the joints. But the question is, so what do we do now if someone has got osteoarthritis in their hands, but it is now getting worse? And is there something else going on, or what should we be thinking of?
Fantastic. Good case. So what we usually like to do is get a little more history before you guess. So is there anything else you'd like to ask? Go ahead.
I would like to ask about inflammation, since we see all the joints are red and swollen. So we would like to see if they are inflamed or not.
Are they inflamed?
Yes, there is some inflammation.
Yes. Other things you'd like to know? Yes.
Rheumatoid fracture, sorry.
The texture of the...
Rheumatoid fracture.
Oh, now you're asking for lab tests. So is there anything else in the history? We tend to jump to the lab tests first so it'll give us an answer. But before we get there, is there any history you'd like to ask? Yes.
Is the pain consistent, or is it worse?
Comes and goes.
Well, it's worst in the morning, but this pain does, the stiffness part does last an hour and a half, so it's longer than an hour.
Yes.
Is the pain mostly in the morning?
It's the worst in the morning. Yeah.
So now what I want...
It's not gone in the rest of the day, but it is worst in the morning.
What I want you to do is open up your minds, because there's more than just this woman's hands, right? So what questions would you like to ask besides her hands? What's that? Good. Let's start throwing out questions to him. Let's make him earn his money. So go ahead. Uh-huh.
How much am I getting paid?
Oh.
0.
You know what? It depends on how well you answer. Okay, so no fever. Great question. Other questions? We're talking about a review of systems. So you start from head to toe. So what other things could be wrong?
Could I see the history again? Because I'm suspecting systemic scleroderma, but I might be wrong.
She's suspecting systemic scleroderma. Any other questions you want to ask? That's the differential diagnosis. Yes?
Does she have renal problems?
Renal symptoms, meaning what?
Renal disease?
I'm sorry?
Lupus.
So you're thinking about lupus, but what symptoms would you like to know if this woman has?
We didn't get to the lab test yet.
Yeah. We try and restrain ourselves from ordering labs until we have an idea of what we need them for. So, yes. Good question. Any Raynaud's phenomenon?
No Raynaud's phenomenon.
Great question. Good. Now we're on the right track. Other questions?
What about her knees?
Her knees?
Her knees are, if you know, they're bony feeling, so it doesn't feel like they are absolutely normal, but she's not really complaining of them. So if the patient isn't complaining of it, many times we don't, investigate that separately.
Does she have any other changes in other joints or the face structure?
Good question.
Okay, so I think if you're thinking about the face, we'll go to that part first. Are you thinking about the changes of scleroderma in the face?
Yes.
Yeah. So that often would be a little bit a later change of scleroderma. Because if you were to, what does scleroderma mean? It means hard skin, right? So where is the skin most likely to be hard? Well, on the fingers, in the forearm, and the course of scleroderma may be that the hardness of the skin starts somewhere, like down in the hands, and then gradually ascends up the arms. It may start to involve the legs. It may even get up to the face. If this is going on, many times there will be some changes in the face too, with kind of a smaller mouth, and sometimes some lines around the mouth. And the patient may not be able to open the mouth to a normal degree.
Now
she doesn't have that though.
Yes. Any other skin changes or GI symptoms?
Okay, so the first part I think we'll say is, anytime that you have people with arthritis, it certainly is good to ask about any rashes, because a number of different diagnoses may have rashes associated. And then, so you can't just ask about one specific type of rash. Probably the most important rash when it comes to arthritis is to ask if they have any psoriasis. In fact, when I was in the clinic a couple of days ago, we saw a patient who had some inflammation in some of these fingers on one hand, but not so much really in the other hand. And so then we said, well, do you have any psoriasis? And she said, oh, well, here's a spot here, and here's some of them. And then we didn't notice it first, but there it was. So there you would say, okay, with that kind of connection, the two things must be related. But she did not have any rashes.
Now you may order some tests.
Okay, you have the request for a rheumatoid factor.
Rheumatoid factor?
Okay, negative.
Next test. Bravo.
Okay, so I'll say that they're, I don't know what what your normals are. I will say that, but the sedimentation rate is mildly normal and CRP is normal. Sedimentation rate is normal and CRP is a little bit elevated. Any other tests you want to order? So, I mean, there was a question about lupus, right?
Sure.
So this would be the time when you could order the full chemistry screen. I think many times when, especially a new patient, you don't know the patient. I mean, I see that being done to get the full chemistry screen. Is that what you see too? That the doctors order?
That would be a glucose, liver test,
and urine test too?
sodium, kalium.
Right? Yeah. And so then with that, you would certainly probably have a creatinine to see if there was any abnormality of kidney function. And probably more importantly, you would have a urinalysis, which would either show you if it was something like lupus, some protein in the urine, and possibly even some red blood cells or a positive dipstick for blood in the urine. So these were negative. No, well, I mean, first of all, I mean, it's more often lupus is a disease of younger people. So people who are in their teens, 20s, 30s, something like that. And it can occur at almost any age, but it is less likely to come on as people get older.
Do we know how to confirm scleroderma with a blood test? I do, but I forget its name. Anticentromere? SC70? What are the
SCL70.
SCL70?
Yeah, that's one test. Again, these are not completely sensitive or specific. So there are different subgroups of scleroderma. One is called limited scleroderma, and one is called diffuse. Are you familiar with those? Okay, so the limited is associated with the anticentromere antibody. People have called it the milder form of scleroderma because it doesn't develop as drastic a changes in the skin. It is less likely to cause renal disease, but there is one complication that some of those people can develop pulmonary hypertension, which is not a good thing to get. So it can be treated, and I see people being treated for it, even in these countries, but so it is more difficult. Whereas the diffuse scleroderma is more likely to affect all over the body, cause much more limitation, and perhaps more likely to cause fibrosis in the lungs that would be also bad, and the kidney disease, which could even go to malignant hypertension.
So we're very anxious to know the anticentromere level was?
Okay, well, it wasn't checked because without seeing if there's any changes in the hands, the raymounds, and the fingers become thicker and they're often blue, and then or any other changes with tightening of the skin, then you are not going to make a diagnosis most likely of scleroderma or limited scleroderma.
So we're nowhere near as detectives figuring out the answer. With the clues we've been...
No, there's one other test that could be ordered that wasn't asked for.
PET scan. No, at this point, I don't know what to order. Any of you guys know what to order? X-rays? Oh, which one? Go ahead, take a chance.
EMG.
An EMG?
Electromyogram?
Yeah, I'm expecting a carpal tunnel syndrome.
That would be a nerve conduction test possibly with EMG. I didn't describe the patient having any numbness in her hands though, because if it was carpal tunnel, there should be some numbness and tingling in the fingers of certain fingers of the hand.
But I think you're thinking that muscles are looking so atrophied that they are shrinking. Maybe there would be a pinched nerve that would cause a shrinkage.
Those questions could be asked of the patient, but then to investigate it, it would actually be sort of a separate issue.
I'm stumped, Dr. Paul.
Okay, well, what were the tests that we ordered, we talked about when the first patient who had rheumatoid arthritis? What tests did we order? We ordered this sed-rate CRP, the rheumatoid factor, and anti-CCP. I didn't hear anybody ask for that test.
That's correct.
Did you? I didn't hear you. I'm sorry, I didn't hear you say it.
I said anti-citrulline because I didn't know the whole name.
Okay, maybe I didn't.
And then you completely corrected me.
No, that was the first case though, right?
Yeah.
But in this case, did anybody say? I was listening to hear, because you asked for anti-rheumatoid factor, right? And I said it was negative. But since nobody asked me for the ACPA test, that's positive.
Okay, what's it mean?
What does it mean?
Does it mean?
It means a combination of rheumatoid arthritis and osteoarthritis at the same time. And I think people were thinking a little bit that could occur in the other case. But if there is inflammation in the hands, even with osteoarthritis, then we have to consider other diagnoses. There are even some other things that we could consider. It's beyond what we could really talk about here. But certainly to look for the rheumatoid factor and other evidence of. And so I think, if you say, well, it's osteoarthritis, but if the patient you're uncertain, it's reasonable to order the rheumatoid factor, the ACPA, and the inflammatory markers and see if those are positive, because at least it gives you something to treat more than you can treat with just osteoarthritis.
Outstanding. Now, I know we've kept you for a long time. I've prepared a case that neither one of them know, and I'd like you to see how they think their way through it, if you'd like to stay. If you'd like to go, we totally understand. You've been a wonderful audience. So would you like to see if I can stump the two doctors? Oh, wow, you guys are mean.
We had no idea this was happening, by the way.
Does Maureen know the case?
Maureen does not know the case.
Oh, then she should come down too.
Oh, yeah, we could do it as a teenager. That would be fun. Yeah, my wife is a pediatrician. We've been married for 35 years. We have 3 children, and she is my rock. She has come to me to Macedonia, to Albania, now to Pristina, and we hope to go to Kazakhstan soon. So she's the smartest one in the room, by the way. However, you could dispute that because she married me, which was not the best move. Okay, so we're going to give the case, and you're going to watch how they do it. This is kind of love.
We could work together.
Phoning a friend happens in real medicine all the time, for sure.
And so already there's a bias, and the bias is because I'm going to use a case that's going to involve these two. They're shifting into a mindset of which things are we sharing as two doctors, right? So they have an advantage already. I'm going to try and sneak my way through that, but they'll get this very quickly. But I don't, again, want you to see if they get the diagnosis. We want to see if you understand how they learn to think, what they do. So if you look very, very closely, this guy over here has a lot of gray hair. This guy has a lot of gray hair. And unfortunately, my dear young friend is starting to get gray hair as well. So there's about 90 years of medical experience or more. If you add my wife, there's over 100 years of experience. We have a lot of experience. We don't expect that you would get these things right. What we'd rather you learn is how to ask allergies, medications, past medical, past surgical history, social history, family history, and then the review of systems. You get the clues as detectives, then you think of the differential diagnosis, and then you order the tests. Instead of a gigantic panel of tests and hope, oh, I'll get an answer because it's a high CRP. We need to think our way through it as we use our thinking. So,
and so what we can do, because literally we had no idea. Honestly, at least I didn't know. Maybe Paul knew that this was going to happen.
But I'm not surprised that he did this.
Yeah, right. He's our ride, though. What am I going to do? So what I think we could do as you're doing this is, as we reveal pieces of information, we can talk about how that changes the arc of our thought. Like having heard this, I go, okay, now I think this, and then if we need to pivot, we can pivot. Does that sound okay?
Oh, absolutely.
Yeah,
absolutely.
Okay.
What we want to kind of do is make this whole process as transparent as possible. Okay. So they're going to make their thinking, they'll comment on their thinking as they go for that. Okay, so the patient is she's a 38-year-old female, and she is an avid hiker, and she likes to spend her weekends in nature. And she's come back to see you because after her last trip into the mountains, she came back with an upset stomach, and she had a rash, and she started to just doesn't feel herself. maybe even some aches and pains and some fatigue. So what are they doing right now? Do you see what they're doing? They're starting to take some notes, right? And inside their brain, what's happening, Paul? What's happening in your brain right now? He's going, when will we eat dinner?
Well, I mean, we have to talk about all of the different things that you have just mentioned. So we are going to have to try and get more information about what joints are involved and how much they're hurting and causing difficulty. We're going to have to get more information about what's happening in her stomach and any changes in the bowels and things like that. And then this rash that you've described, we have to make sure that we check that out.
Great. Patrick, what's going on in your head?
Yeah, so it's funny because one of the things that you have to avoid as a clinician is what's called early closure. So like you start to hear these things and you want to leave your differential broad, your thought broad. So the things I've thought of so far, I go, it's a 38-year-old woman, so I always want to know if they're pregnant. Not that I think these symptoms are pregnancy, but some of the things I might do to treat the symptoms are, would be, or the diseases that I discover might be altered if she were pregnant. So that's always got to be on your list of things to think about. She's a hiker, so you think about exposures, particularly tick-borne illnesses. Are they drinking from the stream? How are they clearing their water? Are they eating different things? Were this is a group of people meeting where they might have been exposed to things their friends had contact with that may not be endemic to the area where they live? So those are all the kind of things, as we start to see how this unfolded, that I'm starting to think about.
Very good. And so the family doctor has done the initial work and told them in their referral to their help is that the woman has an allergy to sulfa drugs, and she also cannot take doxycycline. She has deep sigh there. And then her past medical history, when she was a young girl, she had acute leukemia, which she survived after having a stem cell transplant. Bone marrow transplant, thank you, wife. And she's a survivor of leukemia after her transplant. And her past surgical history includes the bone marrow transplantation. She's also had her gallbladder removed. And her social history, she likes beer very much. And she drinks 1 to 2 beers every day, just with her salad. And she smokes cigarettes. She smokes a pack a day and has smoked since she was 17. Her family history, she has a mother who passed away, unfortunately, from a motor vehicle accident. Her father's still alive, and he has suffered from Crohn's disease. So now they're going to think some more. They're writing down more things. If you'd like to try.
One thing that we should have information to is any medications that she's taking regularly.
She takes birth control pills to prevent pregnancy, and that's her only medication until now, because she thought with her upset stomach she should take famotidine, which she got over the counter, which is an anti-H2 blocker for reflux or dyspepsia. And she's also started to take aspirin, and she takes 4 or 5 aspirin every couple of hours because she just feels achy all over. So you can join this game if you'd like to and see if you can figure it out before they do. And I don't of course, we wanted to let you know that after we're done, we're going to try and find some gelato or something that we can sweet, and you're very welcome to join us. If you guess first, you get to have a free gelato. Actually, we will pay for your gelato, but...
Okay. So I agree with Paul. I think we need a little bit more information about her. I'm sorry?
So they're looking for more information, which we call the review of systems. That's getting information from neurologic, respiratory, pulmonary, cardiovascular, gastroenterology. So after you, gentlemen.
Yeah, so I actually need a little bit more just about her history of present illness. So she went camping, right?
She did.
Or hiking, you said.
That's correct.
Yeah, so did she spend the night out there, or she just went on a hike with her friends, and how long was she out?
She was actually gone for a week.
She'd gone for a week?
And she was tenting. She had a tent and fire and kind of primitive backcountry camping.
Okay, and when did she begin to feel ill? Like during the trip, after she got back? And if so, how long?
Actually, she was feeling ill before the trip, but things got worse after the trip.
Okay. All right. And you said she's having GI distress. In what way is her GI system upset?
At first she started to feel some bloating, and then she started to feel some lower quadrant discomfort, enough so that she started to take the aspirin. She thought that might help. And then on the last 2 or 3 days, she just noticed a little bit of blood whenever she's passed her stools. Her stools have become looser, more loose. Is that bad English? Looser? That's bad English.
No, looser is correct.
Much more loose. And then this blood once or twice in the toilet, which was very concerning to her. That's why she came to see me.
Okay, and the blood was bright red?
It was.
And it was associated, was it intermixed with the stool? Was it after the stool? Drips in the bowl? How did the blood present?
The first time it was drippy, and then she filled the bowl with blood.
Filled the bowl with blood. Okay. Was there also stool, or was she just passing blood?
There was stool and blood.
Okay. Fevers?
You know, she doesn't know that because she's been taking so much aspirin. She may have felt, but...
Okay, right. And then as far as joint symptoms, she had some joint symptoms or muscular symptoms, something else going on. Is that correct?
Does this mean GI doctors ask about joint symptoms? And they
when
do.
There's a rheumatologist sitting next to them in the panel, they do. Oh, yeah, I actually always do. Yeah,
yes,
for sure. If
so
you've got bloody diarrhea, I always ask about
symptoms are kind of, it's a vague fatigue feeling with some achiness, mostly in the proximal joints, shoulders. And
okay. No back pain?
You know, she started to say a little bit of back pain, too, towards the end of the trip, but she thought that was from carrying her backpack.
Yeah. Eye symptoms at all?
What do you mean?
Have her eyes been red? Have her eyes hurt?
Notice the shift to the review systems now doing the ophthalmologic system. And he's thinking in his mind, why are you asking that question?
Well, so here's somebody who has a family history of inflammatory bowel disease, and it's Crohn's, right? Crohn's is more common in smokers, right, which is the opposite of ulcerative colitis. You know, tobacco use, one of the only good things that it will do for you is it does quiet your ulcerative colitis down. So a lot of times people with UC will present when they stop smoking, which you should do if you do it, that it can flare ulcerative colitis, but it tends to improve Crohn's disease. Now, the fact that she felt ill before she went on the trip means this probably isn't the things I was initially thinking about, like tick-borne illness or, giardiasis, which doesn't really cause joint symptoms but can cause diarrhea. And so this could be that this is her first flare of Crohn's. Aspirin's also going to worsen that typically, right? So non-steroidals we try to avoid. So that may all tie into this being Crohn's disease. They can also get inflammatory arthritis. Having a back pain with that is common, but they can also get peripheral arthritis, and you can speak more to the Crohn's arthritis probably than I can.
Well, I mean, the Crohn's arthritis is going to, and this occurs maybe in 20%, tends to sort of parallel the activity of the Crohn's disease. So if she never really had that before, it'd be no surprise that she didn't have any symptoms. But if this became active, it certainly could be presenting as part of the picture with joint disease. And I mean, there are certain rashes that could be seen with these inflammatory bowel disease things. We don't really have a description of any rash, so we don't know if it would be compatible or not, but we'd like to know.
Luckily, she had a cell phone with her, and she took a picture of the rash, and it was a classic bullseye rash, meaning it was red on her shoulder, and it looked like a target. Did she have any eye symptoms? About 3 weeks before she came to see us, she got a red eye on the left side, which she went to the store and bought something over the counter for, and she used it, and the eye seemed to improve by the time she got into the mountains.
Do you have a question?
Where does she live? In Pristina. Of course, I'm making this up as I go. So now they're thinking, now they want to do a physical exam because she's come into their office, done the exam. The rash is fading pretty much so now. And she has a low-grade temperature because she didn't take any aspirin in the morning. She came, her temperature's around 38.4. And she's able to ambulate under her own power. She looks quite pale. Her conjunctiva are pale. And she came in with her partner because she was feeling weak. And her examination of her heart and lungs was basically normal. Her abdomen was tender in the lower quadrants. And on physical examination for her joints, she did not have any synovial thickening. She had no clues on the rheumatologic exam. Any other tests you would like, gentlemen?
So, I mean, one of the, just more questions because she was out in the woods for, some period of time.
And I want you to see this. See, it's so easy to start ordering lab tests because that's what we can do. But what you're seeing Dr. Paul do is think his way through the problem based on his history and his understanding of rheumatologic diseases. So more questions.
So
more
obviously,
questions.
obviously she needs to have water, a source of water. If she's gone that long a time, that's pretty difficult to carry water like that out there. So then she has to get water somewhere out there. And if she was nowhere near a place where clean water is, then she's going to get it from a stream or a lake or something like that. Then what did she do? How did she handle that?
She took with her the latest ultrafiltration system for water.
Life straw, she got to carry that.
Whatever the one is that you can pour your own urine and poop into and you can still drink the water.
Do not do that. Please. And is this the first time that she's ever had these sort of symptoms? Is around the time of this, or has she had recurrent disease like this before and she just happened to come in for whatever the reason she's coming in?
She, in her early 20s, had a similar bout of symptoms, but she was hiking at that time as well, and she just thought it was because she was overexerted while she was hiking. Maybe she got dysentery while she was out there drinking water. She didn't have the filter that time. She did not have a rash that time.
She didn't have a rash at that time. So this is a recurrence of a thing she's had in the past. The rash is new.
Correct. The GI symptoms are a recurrence. Mm-hmm. And I've neglected to tell you that she's had several episodes of kidney stones over the last few years as well.
Okay. Yeah, and so, when you hear rashes in folks, there's different things that you could think about. So when you say you have a target rash, that makes me think about things like Lyme disease, for example, which I actually don't know if they have here. I mean, it's like I live in the epicenter of
Borrelia. Do you have Borrelia infections here? I think in Western Europe,
acute fever maybe,
definitely
kind of things,
Borrelia infections, which produce target rashes, produce arthritis, and
but tend not to cause GI symptoms.
No GI.
Yeah, and so I mean, I don't see people with Lyme disease. My daughter had it, for what it's worth, because we live in the woods in Maryland, and that's a great place to get Lyme disease. If you're interested, come on by. But it is so it's not gonna be that. It sounds atypical for a Crohn's rash too. To be frank with you, I mean, you can get a couple of different kinds of rashes. The most classic would be like an erythema nodosum, which tends to be hard and firm and is on the shins or at least the extensor surfaces.
This sounded more like erythema multiforme, maybe.
Yeah, like an EM rash.
Great. So tests you like to order?
Yeah.
We can move to tests unless you have other questions.
I mean, I think getting a sedimentation rate and a CRP would be a reasonable thing. In my center, I would probably also get a fecal calprotectin level, but that may be.
What was it called?
Fecal calprotectin. So there's been studies, for example, if you look at somebody who...
Has anybody heard of this fecal calprotectin?
Fecal calpro. Yeah.
There's somebody, a few hands.
Yes, a couple of those. So it's super common in GI. And if you look at like the ACG guidelines for somebody presenting with like an undifferentiated diarrhea, for example, one of the ways you can differentiate, for example, an irritable bowel, which is really not the differential, people showing up with rashes and fevers and things like that. And an inflammatory bowel disease is to get those couple of things. And and it's also something you could follow if you want to non-endoscopically follow somebody's resolution of disease. You can follow fecal calprotectin, and that's a useful test. Like we never get fecal leukocytes, for example. Like that's not really a useful test. It's kind of replaced.
I see.
And fecal
I learned
calpro.
something there.
Yeah,
cool.
yeah. Lactoferrin is okay for that, but we prefer calprotectin.
Wonderful. I'm going to get continuing medical education.
And they're actually not that expensive. They used to be, but they're not that expensive.
Paul, you want to assess the SED rate and the CRP were both elevated.
Not surprisingly, with what's going on.
Yeah.
In fact, I mean, I would be very worried that with the description of the patient, I mean, I would like to know what her vital signs are, but if she's really, that pale in her conjunctiva, it sounds like she's actually lost quite a bit of blood already. And you would probably be thinking that you need to know what her hemoglobin and hematocrit is, and to determine if you need to really aggressively treat this, get her probably into a hospital inpatient setting, and make a determination. Does she need something extra to help her?
Outstanding. So we kind of breezed by vital signs as part of the examination, but I did say that she had a fever. Her pulse was 112. Her blood pressure was 90/50. Her respiratory rate was 16. Okay. So the blood test he wants to know. She's pale, and she has. So, what test do we need to order? CBC? Is that what you said? Is CBC? Right. So her hemoglobin was down by 50%. She was very anemic. Her white blood cell count was slightly elevated at, we'll say 13,000, if that's in your same area. So higher CRP, higher SED rate, higher white blood cell count, feverish, and anemic.
Okay, that we want a complete metabolic panel at that point too, because some of the things we're going to give her her renal function may matter to how we dose some of those things.
And she was also dehydrated, so her creatinine was elevated, her BON was elevated as well.
Okay, like mildly, or she had significant impairment on those kind of things?
She had significant impairments.
Significant impairment.
She was in acute kidney injury. She was not needing dialysis.
Okay, and her liver seemed okay?
You know, I haven't thought that far ahead. Should it be? So the last part of the puzzle, and I'll finish it up because you've been such a good audience. The Lyme disease test was positive because she has moved she's originally from Pristina, but she's living in Connecticut. So she was hiking in the mountains in northeastern Pennsylvania. So she did indeed have Lyme disease complicating her underlying new disorder, which was Crohn's disease. Right. So the interplay between, I actually have a patient that is a different, I took some elements from different patients, but this patient had joint symptoms, eye symptoms, recurrent kidney stones, lots of aches and pains, really, and this is this new disorder that I'd like you to just spend a second on, which is this intermingling between connective tissue disorders, rheumatologic, and GI disorders, which are not exactly Crohn's or not exactly rheumatologic.
Well, I think, first of all, I mean, the infectious disorders, especially Shigella, salmonellosis, I mean, both of those could be definitely overlapping. And so, you know, especially when a person is, you wondered if she had been exposed to any places where she could have had those. I mean, if you didn't have some of the other information you came up with, you would probably be wanting to know, is there any, you know, evidence of exposure to these, and did you have any evidence that there was something like this going on?
Yeah, outstanding.
That would be one area. I mean, there are probably any number of areas with things like vasculitis that could be affecting the GI tract and be affecting different systems in the body.
No, I mean, that's what I would say. That a lot of the rheumatic diseases, like lupus, you can get bowel-related symptoms in lupus, which is almost exclusively vascular in nature, like so a vasculopathy, like ischemia that you can get and things like that. I mean, there's also just immune-mediated colitis that you can get. That's usually in somebody who's getting certain sort of what I'll call chemotherapy. They're really immune, you know, like checkpoint inhibitors, for example, that you give for melanoma or those kind of things can cause a very inflammatory bowel disease-like presentation, and you actually treat them like an inflammatory bowel disease, but the trigger is different. Like, to be frank, we don't really know what the trigger is for Crohn's disease and for ulcerative colitis. There are a lot of hypotheses. We go round and round about whether there might be a microbial origin for that. You know, particularly like atypical mycobacteria may play a role. Some of those people get better with antibiotics. We know that Crohn's disease, before we had all these fancy immunomodulating drugs, responded to some of them to antibiotics, particularly for fistula management. You would give them Flagyl and ciprofloxacin, and some of them would improve. And so there's a lot that we don't understand, and there is overlap, and we sort of artificially define these conditions when there might actually be a spectrum. Like, for example, when I was a medical student, you know, and probably even an internal medicine resident, I thought I knew all about ulcerative colitis and Crohn's because I could pull that table out of Harrison's textbooks of internal medicine and say, this is Crohn's, this is ulcerative colitis. And then once I became a gastroenterologist, I saw like these interlocking circles where you have about 15% of people who you just can't make a determination. They have what's called indeterminate colitis. And for a while, we thought that certain serologic markers might help us with that. It turned out that was fantasy, unfortunately, that we really don't use those in the same way nowadays. So there is some of that. And there are probably people who have an infectious trigger that's what kicks them off into that, which is true for a lot of GI diseases, including IBS, actually. They're probably 10 to 15% are post-infectious IBS, and there's reasons why people get that we can talk about. But
now we're going to call it quits. You guys have put in a nice long night. We're hoping that you'll guide us to somewhere where there's something sweet to eat. And there's room for you to join us, so I don't know if there's such a place within walking distance, but we would love to treat you to some time with our professors, if you want to spend some time just talking to them now. But lastly, what I'd like to ask a favor is that we would like to spend more time in Pristina next year. We bring our professors over. We've brought over 150 US doctors through the Balkans already. So if you're interested in doing so, I don't know if Nëntor will be the or who the connecting person is, but whoever that next person is, just contact myself or my wife. We'll leave some information with her, and then we would be very, very honored to come back and spend some time with you. We like to give lectures. That's cool. I particularly like to go into the hospital and see patients and have you come with me so that we can see sick people and we examine them and decide what's going on and how we would take care of them. So we work in the hospital, in the clinics, and also in the lecture halls. So that was an American inviting himself into your country. I hope you don't mind.
But we really like to have interaction too. There's too many times we know where you go to medical school classes and all you get are lectures. And lectures are not always that helpful. I mean, it's hard to remember everything. You don't have a chance to clarify information. So we really like to interact and have it be something we go back and forth.
Our pleasure.
Thanks everyone for coming. I hope you enjoyed the lectures. If anyone has not signed up with registration sheet, can you please?
So he gives us a case of patient to never exist. I was like, what? What? But it's funny because it's like you could, like you're saying, you can have a couple of things. And so yeah. And I was like, this is kind of the EM ration.
I want to thank Dr. Kim and Dr. Maureen for organizing something so good.
That's funny.
And of course, Dr. Paul and Dr. Patrick for being amazing. So. And I would like to ask whoever wants to join us. We're going to Morena to have a coffee or eat something sweet.
I heard an excited noise when she said that. That's good.